if you take the disease pulmonary arterial hypertension, it has a mean life expectancy of 7.5 years, affects mostly women in different ages. It used to be 2.5 years mean average expectancy, but with the current optimized therapy, it's around 7. That's with optimal therapy, and that's without reverse remodeling capacity, basically. These agents are more or less dilating agents, reducing pressure. But if you can offer these patients therapy that has impact on the structure, the underlying structure, you will most likely improve quality of life on top of what's there today, and you would improve life expectancy. So, and that's a new therapeutic mode of action, a new ambition in this field. And there is already an attempt here with a drug that's called sotatercept, which it looks like it has that kind of capacity. It's targeting a more narrow approach, TGF-beta, and inflammation. And our drug is broader, so it's more complex disruption, which we believe might be beneficial, including affecting and lowering TGF-beta, of course. But yeah, so for PAH, this provides promise in addition to what's there. For patients that are at risk for thrombosis, for instance, which is the main killer on the planet for humans, today they have no option to take a drug that doesn't cause dangerous bleeding risks. So with a drug that might have efficacy and no increased risk of bleeding, you could actually combine that to the other drugs and increase efficacy without increasing bleeding risk. But you could also potentially, everything goes well, provide this as the first option of therapy without increasing bleeding risk at all, and then add other therapies on top of that. So the risk of therapy in that case and better efficacy in this major indication.